So, guys, I'm going to suggest we make a start. We loving this
Banter.
this banter together. Good morning, good afternoon, good evening, everyone. It's a great pleasure to be able to welcome today Professor David Hare. David Hare is speaking on one of our global Across project seminars. For those of you who don't know Across, very briefly, this is a global initiative to take home-based cardiac rehabilitation, culturally adapt our interventions to Bangladesh and Pakistan, and then evaluate those in a feasibility and in a randomized controlled trial over the next couple of years. One of the things we do as part of this program is to have these seminars really to try and benefit from the wisdom, such as our speaker today, and really try and capacity build. So it's a very particular and personal pleasure to welcome David first of all, to Glasgow and to this seminar today. I have known David by reputation probably since I began my research in cardiovascular disease. He really is one of the global lights in cardiovascular research. More recently, David and I were both at the European Society of Cardiology meeting in Ljubljana, so we had some time together. But just really briefly, David hails from the University of Melbourne. There's a number of very interesting things about David, if he doesn't mind me mentioning them. So first, I think he was the first individual who was trained in cardiology and psychiatry in the world. So that combination is very interesting, and I'm sure that will come out in his presentation today. But also the fact that David has been nominated as Australian Man of the Year.
Australian of the Year.
Australian of the Year.
Yeah.
Okay, so you take out the gender, just the Australian of the Year.
But I was a finalist, but didn't win.
Okay, so a finalist, but didn't win. But the fact that you were nominated, David, I mean,
yeah,
wow.
but I often lose things in the end.
Okay. And last but not least, and I will wrap up and hand over to David, is that David received the Order of Australia Medal in the Queen's Birthday Honours List in 2021. So, David, it really is a tremendous pleasure to have you here. We look forward to your wisdom. I think the plan is for this to be about 40 minutes presentation, and then if we've got some time, we'll then do some questions and answers at the end of your presentation, David. So we'll hand over to you. I'll move the screen round.
Okay. Well, thanks very much, Rod, and it's a great pleasure to be here, and thanks for your invitation. Thanks to everyone else. Are you going to switch this to? So I want you to share your screen somewhere.
Oh, give me a sec.
So it's just as well I didn't do it. Yes.
Oh, you're fine. Oh, come on. There we go.
Thanks. So we had a few potential topics that we could have discussed, and it seems that Rod thought that maybe psychosocial issues in cardiac patients is where we should target. So that's what I've done for this morning. I've got lots of conflicts. Hopefully the different vectors all cancel themselves out. So yeah, I studied psychiatry after I'd done my basic cardiology training. My professor allowed me to have 3 years off to do it, which most people take 7 years. So it was really hard work. And I decided at the end of that period of time that there are basically 4 psychiatric conditions. So if you want a summary of the whole of psychiatry, this slide is it. People are either sad, bad, mad, or scared, or a combination of all of those. So if you're sad, you're depressed. If you're bad, you're sociopathic. If you're mad, There's some delusional hallucinations there, and you're actually psychotic. If you're scared, you're anxious. So we put nosological names to a lot of people's feelings. We try to cluster things in syndromes so we can communicate, but obviously there's overlap in everyone's symptoms, and our concepts are actually all overlapping. So we're going to focus a little bit on depression. What do we mean by depression? Well, depression can be anything from, I feel a bit depressed and flat this morning, to a severe psychological illness. And being depressed is really the most important driver of quality of life. If you feel depressed, then the whole of life actually feels really bad. If you're not feeling depressed, then basically life's pretty good. And we have classifications, the DSM, which we have 3R, 4, 5 from the American Psychiatric Association. And so they have certain nosological definitions. And as I said, these are clusters of symptoms for communication to try and understand groups of symptoms, but they're not actually, in a sense, a single entity. Like, it's not just an adenoma of a particular part of the adrenal gland that overproduces aldosterone, for instance. They're clusters of symptoms. So there's major depression, and the general population, that's about 6%. There's minor depression. Adjustment disorder with depressed mood is what we used to call reactive depression. And this is the most common in cardiac patients, that they have a reaction to their illness. There's dysthymia, which is fluctuating mood. And then grief means that we have a specific separation here that should improve over time, but doesn't always do so. So the majority of cardiac patients have an adjustment disorder with depression, and by definition, the majority of those should get better by themselves. Now, there's some exceptions to that, like if you become severely depressed as an adjustment, as a reaction to, or if you've had previous depression, then those tend not to improve with just simple cardiac rehab programs and so on. So just to point out that there's overlap in these causes of disability, ischemic heart disease and depression, very high comorbidity in all high-income companies, but heading towards that everywhere in the world. But cardiac patients have more depression than the general population. And if we can see, this data is fairly robust over decades. In the general community, major depression is usually something 5 to 6%. After an AMI, mostly it's about 1 in 6 patients. Patients with heart failure, as John Cleland would know, are usually 20 to 30% with significant depression. Now, we know there's an association between depression and clinical heart disease, and this comes out in all the population studies, and it's true for different categories of depression or depressive symptoms. And when it's looked at general Polish populations, the same thing applies. Independently, depressed people have more coronary heart disease, have more strokes, but we're not sure exactly how much does the heart disease cause the depression, how much does pre-existing depression cause the heart disease. And they both actually are true, but depression causing heart disease is possibly not as big an entity as heart disease producing some reaction followed by depression. So if we're looking at, do psychosocial factors or depression, do they contribute eventually to clinical cardiovascular disease? Well, we need to look at data for incident cardiovascular disease. So we need to follow people with some sort of measurement of depression, social isolation, other psychosocial indices at a baseline, but have a prolonged follow-up, because otherwise we can't make a comment on incident cardiovascular. When we're looking at prognosis after cardiovascular disease, we look at patients that have had an event, and then we can follow them up, usually over a smaller period of time, to see how predictive this is in terms of their outcomes. And we know that there's acute psychosocial factors. We know that there's chronic psychosocial factors. Now, in terms of psychosocial precipitants of cardiovascular disease, we know that acute stress does have some significant contribution, and there's some quite nice data about that. We know acute stress increases the likelihood that you're going to present with an acute coronary syndrome, the likelihood that you're going to present with an arrhythmia, increases the risk of sudden death, and also can have an acute stress cardiomyopathy, which we use the Japanese name Takotsubo, after the octopus pots of the Japanese, where you get apical dilatation with stress. But this was one of the pivotal papers for me, which was very, very interesting. And this is the FIFA World Cup in 2006, published a couple of years later in New England Journal. And what they did is looked at patients throughout. This was all in Munich. And they looked at presentations to the emergency departments throughout Munich and related that to what was happening in games where the German team was playing. And basically, the incident cardiac emergencies that presented were threefold higher for men and almost twofold higher for women. Men and women have a lot of differences that we're not going to discuss at all. Suffice to say that some women get very excited about football. Some men, Scottish men in particular, often behave in quite an unusual way, especially if they lose a match in Europe and they do things to trains on the way back to Scotland. So we've got an increase in STEMIs, an increase in non-STEMIs, and symptomatic cardiac arrhythmias. And here we have a graph, and I've listed there who Germany was playing, and these are labeled 1, 2, 3, 4, the different matches. And you can see when Germany was playing Costa Rica and Poland, these are, pretty important matches, and seem to be more so than Ecuador and Sweden. If we go to 5 and 6, these are getting to the major matches against Argentina and Italy. Unfortunately, Germany lost against Italy. And so where we go down to 7, which you'll see right there down at the baseline, Germany were playing Portugal for 3rd place standing, and it seems like the Germans had actually given up getting excited, even though they had a little bit of excitement in the final match, Italy versus France. And I don't know who the Germans would support in that. But you can see here, compared with baseline, and this is baseline of that previous months, but also baseline of previous years, time adjusted. You can see that threefold incidence in all cardiovascular presentations to emergency departments. So that's very interesting data in my view. Takotsubo stress cardiomyopathy is really an outpouring of catecholamines in an acutely stressful situation. So with the left ventriculography, you can see there on the left, you can see how the base of the heart still contracts satisfactorily, but it differentially affects the apical part of the left ventricle, and get that apical ballooning. And now compared with myocardial infarction, if you look at CMR studies with late gadolinium enhancement, you can see quite a different pattern in the TTCM, the Takotsubo cardiomyopathies, stress cardiomyopathies, quite different when you get an anteroapical infarct on the MRI. So they're quite different. Chronic stress is another interesting one. And we've even got non-human primate data for that. And some of that was published as long as 40 years ago in Circulation. And if you create a psychosocially stressful situation for non-human primates, and they're not dissimilar to human primates. Sometimes I feel more like a non-human primate, but we all have different feelings at different times. But they actually developed more atherosclerotic vascular disease, which is fascinating. Because remember, most animal species do not develop atherosclerosis on their native diets and in their native situation. So you have to give them, and there's some animals that never do, like you can't do atherosclerosis experiments on rats or dogs. They never get atherosclerosis, but you can make rabbits, non-human primates, hamsters, other sorts of animal models. So if you take non-human primates, you have to give them a background of some atherosclerotic diet, because on their natural diet, they don't get it. And if you look at different sorts of stress, including their social status, aggression, response to psychological changes, and instability of their social environment, these all do increase atherosclerosis. We have some similar data in humans, and we have good data, obviously, from Whitehall. There's always Michael Marmot's started studying this, I recollect, probably back in the early 1970s, when Michael started this sort of work with, bus drivers versus bus conductors and all these sorts of studies in the old days. And but this is Scandinavian data, but you can see in this particular multi-cohort study, more than 100,000 participants, 7 European longitudinal cohorts. They've pooled the individual participant data. So this is not just a meta-analysis adding up the variances of different studies. This is actually putting in the primary individual data and putting it together as a meta-analysis of primary data, not just statistically analyzing the variance of the different studies and adding them up. So it's pooled individual data, Finland, France, Sweden, and they included Whitehall too, and people without any cardiometabolic disease. And there was definitely an increase in mortality. I was asked to do an editorial for this particular study, and I find these studies epidemiologically like this, hypothesis generating, but not absolute proof. They mean it's probably true, but it's very hard. If you go back to Socratic method of inductive reasoning from analysis of data, then you form a hypothesis and you have to try and, in deductive reasoning, see if you can prove whether it's true or not. Well, you can't do it in these settings. So you never know the actual answer. But the risk is always, is there complete control of covariates, such as, and I gave an example, social isolation, which is a powerful predictor of mortality in people in general, with heart disease, without heart disease. If you're socially isolated, you're more likely to die. Some people try and differentiate that. Well, are you just isolated or do you feel lonely? But put aside that difference. But it can be that there are other factors, such as different external stresses, other things that are not measured. And to get the pooled individual data, a lot of these studies didn't have things like social isolation. They didn't all have education in it, financial status, things that are major predictors of mortality. So very important data, probably true, but not necessarily. It could be some other covariate is contributing to the mortality, like poor access to health facilities, as a covariate increasing mortality that is also associated separately with the work stress. It's very interesting that fear of future loss, and a loss model is very good for cardiac patients. So if we look at a loss model, it's good because if you're frightened of what might happen, you become anxious. And if you think you've actually lost something, you feel depressed. And this is quite important. Now, there's also psychosocial predictors where we wonder whether things are risk markers or risk factors. That's like HDL cholesterol. HDL cholesterol is a great risk marker, but not a risk factor. And every trial we've done over years to try and put up HDL cholesterol does not have any benefit in reducing events. So HDL is a risk marker, and it could be some of the things we're talking about, like depression, social things, are markers, but not only actually factors. We don't actually know the answer to that. Obviously, there's some data for CRP, and Paul Ridker obviously is a great believer in that. And it certainly enriches events. If you want a primary prevention study of statins in a primary prevention setting, you can actually do Jupiter in a primary prevention setting, getting enough events by putting CRP in to enrich the later events. So we can talk about increasing incidence, which is etiology, worse prognosis, worse outcome we call prognosis. So are psychosocial factors risk factors? Well, there's some data, related to it being risk factors. The issues there are obviously have to have objective longitudinal measurement at baseline of coronary heart disease, prospective measurement of that, characteristics of the association, and a lot of, all this stuff that has to be biological plausible. Then it's to get that deductive part where you set up a trial, it's nice to intervene, show that reversing something actually changes it, and then it's what the Americans call a slam dunk, which card players will call an open misère, but it becomes pretty well proven. So we have data on AMI etiology and then mortality 17 years later. And this is quite an important Danish study done by Barefoot, who was actually from Duke, but Danes are good for data, Duke's quite good for analysis. And so depression was assessed 1964 to 74, follow-up 17 years later. And basically there's a doubling of coronary heart disease incidence. This is a study I was involved with. This is a Finnish study called the Young Finn study, and they had a whole lot of data collected in children. They were adolescent children, early adolescents, and they looked at all their LDL cholesterols, their ApoBs, the LDLs of their parents, the ApoBs of the parents, the blood pressure of parents, and numbers of psychosocial factors. And then numbers of years later, when they're in adulthood in their 30s, we did coronary calcium scores, and we found that certain psychological factors in childhood predicted coronary calcification when controlled for all the covariates that we had measured that were massive. And so we're looking at 28 years later, CT studies measuring the calcium when they're in their 40s. And sure enough, it did actually predict, and favorable psychosocial factors had less coronary calcification 28 years later. One of the interesting factors, these are very significant, tightly controlled for all these risk factors. So it's pretty tight sort of data. The interesting thing in the psychosocial factors was it was only parts of it. And and it was, particularly related to certain ways that they coped with stress, patterns of behavior that they had in adolescence that could have affected so many intermediaries on the way. Kids that took control of their lives had a good outcome. Kids who felt victims in life and didn't feel they had control had bad outcomes. This is true of adults. It's true of adults with coronary heart diseases, true of adults with heart failure. So these are all, consistent findings. Don't forget Salam Yousaf's Interheart study. Again, this is a case control study, multiple countries, and number one was ApoB, ApoA ratio, and he looked at this at what we call the attributable risk, not a risk ratio, hazard ratio, the attributable risk calculated, ApoB, ApoA. So that includes, LDLs, the size of LDLs, number of LDL particles, HDL will all be included in this ratio. Number two was smoking. Number three was psychosocial factors. Number three in all the world. Number three, very powerful, controlled for all other factors. And these were mostly social isolation and depression. So we've also got the issue of whether it affects prognosis. And we've got Ruberman's original study. Some of you who are as old as I am, nearly 80 years of old, might remember the original ISIS studies of atenolol, the Norwegian timolol studies, the BHAT study, randomizer of propranolol, and these sorts of things. But the biggest predictors of the outcome was actually life stress and especially social isolation. So social isolation, right back in Ruberman's study, which was published over 40 years ago, was incredibly powerful as an explanatory variable. And it had covariance also with low education and some other things. In this particular diltiazem post-infarction study, that didn't end up being as good as beta blockers. And beta blockers, by the way, in studies done now with preserved ejection fraction, small heart attacks, beta blockers, not much advantage. In the old days, bigger infarcts, beta blockers, very powerful and had a major effect. But in the bigger heart attacks in the old days. But in this one of diltiazem, not much use giving diltiazem after heart attacks. But if you were living alone as distinct with others, you had a hazard ratio that was 50% higher of dying if you lived by yourself. Bad. Does living with someone else make a difference? It depends on who you live with. Sometimes that increases social stress and it might be a major disadvantage. Maybe living with a nice, compliant little pet dog might be better. I don't know the answer, but it's a separate covariant. And we've got all Nancy Fraser-Smith's and Francois Lesbrong's work from Canada after AMIs and unstable angina, and you get stepwise, changes. So there's overall depression is about a 50% worse prognosis after existing diagnosed coronary heart disease. We looked at depression after AMI, and then we looked 25 years later, and this was consecutive patients, all of whom were rated for depression. And then we looked at the mortality from the Australian Institute of Health and Welfare mortality data. And even mild depression predicted all-cause mortality 25 years later. So that was quite interesting observational data, but significant. This is one in heart failure patients, which is interesting, and we'll get onto this in a little while before we finish the end of this. But there are different components of depression. And depression is not all just depression. And in fact, when you measure depression properly over a whole range of different symptoms, you end up with two principal, on your Oblomov first order factor analysis, you get two major factors with a lot of shared variance. And then within that, you get 7 sub domains, which are all different parts of depression, like sleep, like irritability, and that will be separate to feelings like hopelessness, for instance. Now, when you look at the hopelessness part of depression, which is a separate domain, it has shared variance with all the rest of depression. But when we looked at hopelessness in heart failure patients, and then we had about 40 covariates we controlled for in these consecutive patients, but we controlled for functional class, ejection fraction, left ventricular end diastolic diameters, EGFR, hemoglobins, age. We controlled for everything. And the CDS hopelessness there, that's hopelessness is a measure on our cardiac depression scale, where hopelessness is a separate dimension, but with a lot of shared variance. We showed it was a major predictor of subsequent mortality in heart failure patients, so very important. These are some potential mechanisms, and I put this one together for Tom Lushka asked me to do this for European Heart Journal, so I won't go through that in detail. We did a study, and I decided to look at Australian cardiologists. There's under 1,000 Australian cardiologists, so not a lot. But we sent out invitations for them to find out what they thought about depression and heart disease. I got approved by the board of the Cardiac Society of Australia and New Zealand, and we got a return rate of 63%. The highest in any other study was 12%. How did we do it? 63% because I wrote personally to every single cardiologist in the country. Dear Bert, nice to be in contact with you again. How's your wife, Myrtle? We were wondering whether you might like to, and I did it personally. And then if they hadn't answered, I had a feedback loop and did it again. We got a 63 response from cardiologists. You've got to be joking, but because it wasn't about a stent. So it was a non-stent questionnaire. And only 3% at that stage were routinely using anything to measure depression. And the majority didn't see it. It's nothing to do with me anyway. It's to do with their doctors, their whatevers. But I don't do that. I do imaging. I do CMR. I put in stents. I ablate AF, but depression. You got to be joking. So that was sort of the response I got from Australians. Now, there's numbers of tools for detecting, diagnosing, measuring depression. Most people focus on screening for depression. That's fine because you've got to screen and you need simple tools to screen. But you need to actually diagnose. You need to be able to measure. You need to be able to measure dimensions of it. And you need to be able to monitor over time. Otherwise, you've got nothing to look at in prospective studies. You've got to have data that can move distributions over time differentially between randomized groups. So we developed the cardiac depression scale, and a guy, Tom Hackett, who is professor of psychiatry at Harvard Medical School, was the one convinced me to do it because he said there was nothing that had ever been developed that was useful in his view. Like, he didn't think HADs were any good. He didn't think Becks were any good. He didn't think Zungs were any good. He thought Hamiltons were totally skewed because they were all developed in psychiatric populations. So he talked me into doing this years ago. So it's the only scale for depression was actually developed within cardiac populations. And it can assess the whole range of depression in cardiac patients. It's a pure normal distribution, perfect kurtosis, no skewness, no transformation of data needed because of skewness at all. And it was designed to sensitively measure changes of depression in outcome studies, because none of the other tools could do this. And most of the neutral studies was basically because all the things like the Hamiltons, the HADs, and everything else were just clumsy things that couldn't measure anything. So the American Heart Association thought they recommended a two-step screening using the PHQ-2, followed by the Patient Health Questionnaire 9, and pretty sensitive. This is for diagnosing depression, but poor specificity, like half the time they were wrong. And if they just asked the question on the PHQ-2 alone, yes, no, the sensitivity was about the same. The specificity was actually better. So, but the reason for that is the PHQ-2 questionnaire, there's 2 questions. Over the last 2 weeks, have you had little interest or pleasure in doing things? Feeling down, depressed, or hopeless? These are the 2 questions, yes, no. And the major depressive disorder criteria on DSM-3, 4, and 5 are basically the same. You have to have 5 or more symptoms, but 2 are essential: depressed mood or loss of interest or pleasure. So basically, the PHQ-2 is a self-fulfilling prophecy, because it just puts in those 2 things from the DSM-5, and so that's what you get. That's why you get sensitivity, but you don't get specificity. And you can't use it to compare between groups. You can't use it for change over time, but it's still the best over all the others in the sense of sensitivity, 0.9. And when you look at the best spot on the under the curve of the AUCs on the receiver operating characteristic curves. Now, when you look at the cardiac depression scale, you'll see this was our first publication, actually, which is now 30 years ago. But you can see it's got a beautiful, perfect kurtosis, no skewness, measures the whole range of depressive symptoms. Sensitivity, 97%, specificity, 85%. And on the receiver operating characteristic curves, AUC, area under the curve, 0.94. Everywhere we look at this, it's always just as good. So compared with the PHQ-2, it's clearly way better. But what else does it do? So you can measure different dimensions of depression with 7 subdimensions, and they all have clinical outcomes, as I mentioned to you, with heart failure, like hopelessness predicts mortality, but other measures of depression don't predict mortality. It's reproducible. When you do test retest, the standard deviation of difference is really, really tiny. It means you only need really small numbers to show change over time. And that's very sensitive to measures over time. So when we first tested it, say, in a rehab program, we could reduce depression by half a standard deviation over a 6-week rehab program. That's crazy. And that means you only need about 30 to 40 patients per group if you've got paired data for each of the groups. But also, it's, as I mentioned, when we're looking at the different outcomes, I mentioned that study we did as an independent predictor of all-cause mortality. That's hopelessness, but it's not other parts of depression. So these other tools for detecting depression, obviously you can't do any of this stuff at all. And we've also validated multiple languages, multiple countries, multiple cardiac. We've looked at it in probably about 20 different countries, 20 different languages, multiple cardiac. It's always the same, and it tends to have this very high sensitivity and specificity. This is data from the People's Republic of China, for those of you who read Chinese, which I don't, and I'm making an assumption that what people told me they'd done was true. But you can see there's similar, very nice normal distribution, very nice mean scores, and so on, and externally validated. We externally validate as well. This is an Iranian one. We did this in the Azerbaijan province of Iran, you know, not far from up the north on the sea there. But Cronbach's alpha for the whole 26 items. For the Iranian, that's I-CDS. Cronbach's alpha 0.88. Fantastic. That's Cronbach's alpha, that's internal reliability. So it means everything's hanging together. If you don't have high internal reliability, don't put the stuff together. And that was the problem with the Minnesota Living with Heart Failure questionnaire. When Jay Cohn and Tom Rector put that together, they had two factors in that had almost no shared variance and nothing on Cronbach's alpha, and yet they still put out Minnesota Living with Heart Failure questionnaire, a trashed heart failure studies for nearly 2 decades until John Spertus came along and showed them how to do it. Okay, so there's 2 principal factors. It's exactly the same. I'm using this example because I could show you the Turkish data, the French data, the German data, the Greek data, the Italian data, the data from Jordan in Arabic or whatever. They're all the same. Okay, same 2 principal factors, high Cronbach's alpha, 0.88 for factor A, and B, 0.70. So the initial cluster of mood, inactivity, sleep, hopelessness, uncertainty, and all those all come out in secondary factor analysis separate as well. In the first factor analysis, anhedonia and cognition hang therein together. So anhedonia is like, well, an is always nothing. Hedonist is someone who loves pleasure. Anhedonia means I feel bad, I get no pleasure in life, okay? But it works. So we validated a short form of the CDS, and that carries way more data than PHQ and all these other things. So feeling in poor spirits, which is like the anhedonia part, which is one of the principal items in the DSM criteria for major depression. But you see Cronbach's alpha 0.84, and this is, you know, for the short version, but you can see these principal components analysis. So all these, so we validated the short for, and just with these 5 questions, great data. Now, does treating the heart disease or treating the depression or both is important? I'll put up this one, this guy here, single patient, cardiac depression score. He had cardiogenic shock, left hospital in cardiogenic shock because he'd been in a general medical unit, and he was sent to me with I could only take his blood pressure at the wrist. He had such poor cardiac output. Clinically, he had about 15 to 20 liters of ascites, guy aged 33 years. And they said, heart failure clinic, next available clinic. Okay, so I saw him at the start of January. CDS score 129. That is major. That's close to death and feeling like you're dead. Okay, over 3 months, we treated his heart failure. I couldn't get any beta blockers on board for the first 4 weeks because we had no blood pressure to play with. So we're mostly in mineralocorticoid antagonists and, you know, all that sort of stuff. Down to 99, 47, 35, 26. That's 0 depression over 3 months. Non-pharmacological treatments, we won't go into the details of these. Suffice to say, we started talking about this. I spent some time as a medical director at the National Heart Foundation. I wrote this paper 1986, so that's 40 years ago. And basically everything I wrote there, nothing's really changed. It's just the same. We just put it in different ways. Bob Lewin did this in Lancet, comparing a randomized trial he put in Lancet of rehab versus no rehab. Bar Taylor was the first one at Stanford, and I've cut and pasted this from one of my original slides before we had PowerPoint. So one of the old ASO slides. So Bar died about 4 years ago, but an absolute legend in this sort of area. And he compared group training, exercise testing without training controls. If you went to an exercise training program and he did the depression on the Hamilton scale, he was also very keen for me to do that CDS as well. So he pushed me into it, as well as Tom Hackett at Harvard, and Barr was at Stanford. But depression at 6 months, majorly down with the group exercise. And the intensity of exercise, we did this in randomized trials, and we randomized patients to vigorous gymnasium exercise after AMIs, even those that had pulmonary edema. We had them in, we did repeated exercise tests, target heart rates, all that. Then we compared them with a light aerobic exercise program. And basically, we found that the aerobic program, they got fitter faster and then plateaued off after 3 months. And the light program kept improving from 3 to 12 months and reached them by 12 months. And then we looked at depression, which we published in the BMJ. And again, there was no difference in depression. Heart failure action showed that exercise actually improved depression, and also a suggestion that it probably reduced death and hospitalization as well. Pharmacological treatments, we won't talk about in detail. Suffice to say that before an AMI, if you're severely depressed before and you're severely depressed after, you can respond to an SSRI. Otherwise, you do not respond. And what happens is the control groups all get majorly better. You can see that control groups get better with usual care. Most of the improvement is the control group, and only a small component for the drugs. This is Jim Blumenthal, 3-way randomization, coronary heart disease patients, 4 months aerobic exercise, sertraline, or neither, 3-way. And basically, comparing them, if you got the exercise, you were fitter. If you got exercise or sertraline, you actually were less depressed. So exercise, in my view, was actually better overall and as good as sertraline in general. What about in heart failure patients? This is Christina Angerman's study published in JAMA. SSRI, she used escitalopram as we did. No difference treating depression in heart failure patients. And this is our data. No difference in SSRIs. These are randomized trials. So SSRIs useless for heart failure. Role of self-efficacy, we've looked at that in adults. We looked at self-regulatory behavior in children and what happened 28 years later. So self-regulation, internal locus of control, which is like self-confidence, is very important for improving the situation for patients. And there's lots of reviews there on stuff, and I finished. Thank you very much.
Thanks. Claire, are you happy to put us back on again? Sorry. David, that was an absolute tour de force. Thank you very much indeed. I knew that David would be the perfect individual to talk about psychosocial issues in heart disease. And David, you've demonstrated that beautifully. So we've got 10 minutes, I think, David, if you're happy to take some questions.
I can sit here all day if you want me to. I've got nothing else to do.
Well, we need to feed you, and we've got our international steering committee.
Bring me a coffee, I'll be fine.
Yeah, and Claire will bring you a coffee, maybe. So questions for David. Who would like to go first? Please pop your hand up, and then I'll spot you, and then you can come in.
So usually questions come to the top of the list, don't they?
I haven't turned on the.
So
John's got a question.
John Cleland. John, yeah, please fire away.
Just breaking the ice.
Thanks,
fantastic talk, and I absolutely concur with your views on patients with heart failure.
Yeah.
I've always thought that there are people with innately depressive personalities, and and then you had your grieving and your dysthymia, etc. So I think, for me, I've always thought that with the patients with heart failure, yes, a lot get quite depressed when they get a diagnosis or when they get an exacerbation, but their ability to come back for it to resolve is quite remarkable. So the humans are really great. I've always wondered a little bit about denial, and denial is a very good coping mechanism for some patients. But perhaps the other issue I'd like to raise, which really irritates me in a lot of quality of life type studies in cardiovascular disease, is people use the quality of life as a prognostic marker. And for me, that demeans the value of quality of life. Why the hell are people using quality of life as a marker of prognosis? Its great value is in itself.
Right.
I often heavily criticize papers that come forward and saying, oh, great, we can use our KCCQ or Minnesota to predict prognosis, but why would we want to do that? And your chap with really severe heart failure, you showed that you improved his treatment and it improved his depression. Surely it's the improvement in his depression that was the most important thing. And he just happened to improve his prognosis as well.
Okay, so the first thing was, are some people more depressed than others in the personality? The answer is yes. And so there's some depressive characteristics of some personalities. Doesn't mean they can't change, but same as some people more anxious than others. The other thing related to endpoints and what's important in life, basically in cardiology, we do two things and only two things. We make people live longer or feel better. That's all we do. And the rest of it's all surrogates for feeling better. So feeling better, which is your quality of life, is number one. Even hospital readmission. I understand it costs money and all those sorts of things, and we put it in all our studies because that's how we work out whether we can get our programs funded. But it's actually the way the patient feels is so important. And these are not secondary endpoints, as you allude to, John. These are equal co-primary. You want to be alive until you're so old that you want to be dead. And in the meantime, you want to be fit, well, and have a good quality of life in the meantime. So that's number one. Number two, related to interventions, if you want to put together a meta-analysis of all the CRT trials, which I know has been done in the past through people who you might recognize, yourself having been the prime mover in that. But if you look at treating people well with heart failure, that is the key thing that makes them better. And we've made them better in our trials, and we've had them all on beta blockers, spironolactone, ACE inhibitors or ARBs, randomized them to medicines, and we've used escitalopram as an SSRI versus placebo. We got the placebo escitalopram from Denmark because that's where they manufactured it, and there is zero effect. So how we handle patients in our rehab, and we've got data for rehab, how we handle them in just our diuresis, the biventricular pacing, the different treatments is absolutely crucial, not only to mortality, but to the other thing which we all want for ourselves and for our patients, which is making life better, not just longer.
Yeah, so I agree. I'm trying to push an endpoint I call alive and well. And that's what we want to do. Will you be alive and well in a year's time?
Thank you, John. And just a call out for John. So John's our former director of the clinical trials unit here in Glasgow, but you can hear very eminent cardiologist, published many trials. And John, thanks to your direction, as you know, that Alive and Well is a secondary analysis of our REACH HFpEF trial that we'll be doing this summer.
Yeah.
So great work. David, I wonder if I could ask you a couple of practical questions. So I'm intrigued by your very initial statement that prior depression to a heart disease diagnosis can be more difficult to manage than maybe those that get it later. What I want you to do is to think about our across trial now. So very quickly to remind you, we're recruiting people into that trial who have either coronary artery disease, so acute coronary syndrome, they've been revascularized, they've had a cabbage, or they've got heart failure of either flavour, preserved or reduced. But they also have to have either depression or anxiety, and we'll screen them on the PHQ-9 and the GAD-7 respectively. Where I'm coming from is, should we be thinking about pre-specifying a subgroup analysis according to whether people have those, either their anxiety or depression preceding their cardiac diagnosis or not?
Yeah.
Is that something it would be sensible to do,
Yeah.
you think?
Well, first of all, cabbage patients behave differently to heart failure patients, or behave differently to AMIs. And definition of AMI, as you know now, is, oh, my troponin went up a little bit. I better get a stent and then go home tomorrow. So, the definition of AMI has changed historically over time. So you really need to carefully, preferably stratify for all of those to start with. Otherwise, you certainly need to pre-specify if you don't stratify. But the other thing is that all the data, like for the SSRIs, like with sertraline in patients with ischemic heart disease, they only worked in those with more severe depression and those who had pre-existing depression. So in my view, you need to actually measure the depression beforehand. The PHQ-9, well, that doesn't give you any useful way of measuring change over time. It just says yes, no. I mean, really, that doesn't tell me much about anything. But it gives you some categorical information. So I think to have categorical information at baseline and pre-specify the outcomes is important to do it. I think you're not doing it in the best way.
Okay. Thanks, and we'll pick that up when we have our international steering committee, because I know you made that point at the first meeting, and I think we've responded to it, David. So stratification, absolutely important, because if you've got so much heterogeneity in there, you've got to be careful. You're going to have balance across your groups.
Absolutely. Yeah.
So I think we've got a question.
Unless you've got very large numbers.
Yeah.
So if I'm at Oxford University in the Oxford trials group, you say,
and you're with Rory
Rory's an old friend of mine from decades back, but Rory always says, don't stratify anymore, just get enough patients and it all comes out in the wash. Most of our studies are not as big as those massive studies, and therefore it is important for us to stratify, even though the Oxford trials group might say no.
Yeah, well, we can all dream of mega trials, and Rory often does, but those mere mortals like ourselves that are not pharmaceutical company sponsored, maybe just have thresholds like 1,000 patients in our trial. But anyway, I'm conscious we've got a couple of comments online. So I think we've got, first of all, hand up from Carolyn, and then next I think we've got Jamaluddin. So Carolyn, psychologist based at the Heart Manual office in Edinburgh. So Bob Lewin's group originally, but Carolyn, the floor is yours. Go ahead.
Thank you for your talk. I've got quick questions.
3 questions. You can have one, Carolyn. You can have one.
Should we be using the cardiac depression scale in our national audit of cardiac rehab in this country?
Yeah, the answer to that is yes, because it's the best tool, obviously. It depends on if you want to just dichotomous depression, yes, no, well, okay. But if you want to be able to pick out other stuff, which includes things like, but do I feel hopeless, or, different components of depression. And also, if you want to look at change over time, don't use a PHQ for looking at change over time. There's no good data for PHQ changing over time. It's just good for a yes, no at some point in your life. Well, good on you. But if you want to measure any change over time, you need something like the cardiac depression scale. My personal view was yes, because that's the whole reason that we did it in the first place, not just for fun. Yeah.
So how do we convince them? That was my second question.
That's another question, and I'd have to understand the personalities. I would have to know what their favorite wine was, their favorite restaurant, and also you need to also so you have to have personal interaction is the only point I'm making there, as well as data to present.
Right, okay. And should we be using it in a cross trial?
Well, maybe that's one that we can discuss with David in the International Steering Committee. But I guess to that, do we have a validated version in Pakistan and in Bangladesh? Do you know, David?
Yeah, so we've got, as I said, we've got a validated version that has been done in Hindi, but that's not published. We've got a couple of studies done in Arabic, and we've got it in Farsi, but in the different, because the language of Pakistan, and you need to have it valid, but it's quite,
it's language and country, isn't it?
Right, and so there's nuance of language, and so to do these things in the different countries that we've done it, you have to do a forward translation, and then you get a totally independent group to do a backward translation, and then you've got to have someone outside looking at the internal consistency of the items. When you have that on face validity, then you can actually give it to a population. You don't need a big population. You can make this run even with 120 individuals, and then you can do a factor analysis of the version that you've back translated to check its internal validity. And then you only need to give it about 120 or so, 150 people. And then you can do your Cronbach's alphas, your factor analysis for that particular subpopulation, which might be a slightly different dialect in the south of Pakistan to the north of Pakistan, because they are slightly different. And some of them have got a language that's closer to Farsi. But you'd have to, it'd be simple to do, but you'd have to have someone to do it.
Yeah, we should talk about that more.
It's a separate study.
Yeah, because we've got a couple of PhD students who'll be based in Pakistan, and a couple of them have got a particular interest in
it's a
psychology.
Perfect PhD study.
Yeah,
or even a master's study.
Talking of PhDs, I'm going to give the last question to Jamaluddin. So Jamal is a physiotherapist based in Dhaka. Jamal and I met when he was in Europe, finding out more about how we do cardiac rehab. He's just completed his PhD. He's done a validation of the heart qual in Bangladesh. Right. But Jamal, your question for Professor Hare. Go ahead.
Thank you so much. It's such an eye-opening presentation. I am delighted to actually hear the presentation. So my question is specifically that in the South Asian region, there is a huge number of cardiac patients in the double burden of depression and anxiety, according to the society situation and the family and the financial crisis. So as far I understood that in this region, there is no validation of CDS cardiac depression scales as in China maybe. So do you have any plan, and how could we execute this validation process? As Professor Rod Taylor said, that we have in heart qual validation in Bangla version in Bangladesh.
Yeah, sure.
So how could we progress?
Yeah, we'd take that offline, obviously, not as part of this meeting, but get in contact with us offline, and I can send you publications that show how to do it and what you need to do. Because basically you need a translator, you need backward translator, you need someone who's going to assess the equivalence for face validity, and you need a statistician. And with that, any master's student could, even an honors student, could potentially run it as long as they were supervised. but we can give you backing to do that if you, because you know, the nuances of, a good example was when we validated the Chinese version, when they put the full 26 number, item 26 of the 26 just happens to be about sexual activity, and to the Chinese, that was an affront. And we didn't know that. And so we had to modify the Chinese version by one item to take into account that particular item. Now, that didn't seem to worry Turks, Iranians, or anyone else, but the Chinese or the French or the Germans. But that one item seemed to be a problem with the Chinese. So there are some nuances, some sociological nuances that do occur in different people subgroups. But as you rightly point out, you know, in this South Asian population, not only do you have very high levels of lipoprotein little a, you have very high levels of metabolic disorder with insulin resistance. You have very high levels of triglycerides. You have lots of small LDL. You have quite high levels of smoking. So you got a whole lot of stuff where it's basically really bad for people. But getting hold of the depression and anxiety side, in my view, is equally important. The other interesting thing, when we're doing the studies in different countries, I actually look at the mean depression and the standard deviation for the countries. And it was quite interesting at the time we did the study in the Azerbaijan province in the Farsi language in Iran, the Iranians who were coming in with heart disease, on average, were half a standard deviation more depressed than Australians, which is interesting.
So David, maybe a great point to finish on. So I'm sure I speak for everybody by saying that was just a tremendous presentation and also discussion. So huge thanks, David. I'm just going to close with the fact that there is a country that has made the World Cup this year, and you're in that country now. And I'm absolutely sure that by the time we get to the final, whether there's any Scotsman still alive at that point,
Yeah, that's right,
because of their anxiety.
alive to trash a train or something.
Yeah, or to even tell the story.
Yeah.
That will be interesting. But maybe that's another bit of analysis for another day. But again, David, huge thanks. We really appreciate your presentation. I know we've got the benefit of your wisdom in the International Steering Committee, which we'll be having in an hour. But I'm sure everybody, again, would like to say thank you for David for his wonderful presentation. Thank you very much.
Sure.
And thanks to everybody for joining online. We probably will have another, well, we do have another across seminar coming up. David, do we know when that is?
So it is
In about a month's time.
so it is on the 28th. I think no, sorry, 21st of May, 1 till 2 UK time, and it's been led by Jamal and his PhD work.
Okay. So hopefully you heard that. So we've got our next seminar on the 21st of May. If you're not on the Across Mail list and you would like to attend our seminars, you're more than welcome to do so. We always run them online. Just drop a note to either Claire or David, Innes that is, and we will add you to the mail list, and do join us for our future meetings. But again, thanks for joining today. Bye for now.